So here we are, finally having the opportunity to talk about one of my favorite joints in the body, the shoulder complex. We call it the shoulder complex because it's more than just a joint. There are a number of joints associated with allowing normal function to occur at this unique region in our body. It functions as a gateway between the hand and the trunk, and the hand and the hip, and the hand and the big toe for that matter. So let's review the anatomy first, and so we have a better understanding of what's there before we talk about the unique mechanical characteristics that make this joint so much fun, so interesting, and so dynamic to review. So let's take a look at the humerus, the distal articulating bone of the shoulder complex, and we have some landmarks that we need to be able to identify. So if we start at the top, work our way down, we start with the head of the humerus, which is that relatively cylindrical structure that fits against the glenoid of the scapula. And we'll take a look at that articulation in a little bit, but just as a reminder, we can recognize that the humeral head is actually quite a bit bigger than the actual size of the glenoid. So there is a portion of the humeral head that is a little incongruent with the scapular glenoid fossa. So I move down, I can visualize the anatomical neck of the humerus, and that serves as a point of attachment for the capsule. And occasionally I'll have people that will have a fracture at the humeral head or at the anatomical neck, which are always a difficult fracture to treat because they inevitably also occur some type of trauma to either the lesser tubercle here or the greater tubercle here. So if I come back and look at that lesser tubercle, it really serves as an attachment site for the subscapularis. So when we look at the muscles, we'll come back and visit that again. The lateral tubercle, if I turn around here a little bit, is a lateral attachment and moves slightly posterior and acts as the attachment for the supraspinatus, infraspinatus, and the teres minor. What we can visualize between then is a groove, the bicipital groove, where the long head of the biceps courses through between the two tubercles. So the long head of the biceps, held in place by the transverse ligament, will provide stability to the glenohumeral joint. Actually can work as the long head of the biceps tendon can actually work as a humeral head depressor, in addition to the role that the rotator cuff plays. So I continue to kind of look further downstream here. I have the surgical neck, which is a narrowing on the neck of the humerus, and another site that we often see as a fracture site. So hence that term surgical neck for the need to surgically repair fractures in this area. The length of the bony length of the bone is just the shaft, and then laterally we have the deltoid tuberosity. So let's take a look at the scapula, and this is one of my favorite bones because of its complexity and function and the multitude of attachments that occur. So one of my quiz notes here is to be able to identify all the muscles that attach to the scapula. And keeping in mind that we have muscles attached from the thorax to the scapula that are scapular stabilizers, and then we have muscles that attach from the scapula to the humerus, which are humeral movers, and then we have muscles that attach from the thorax to the humerus. So we need to have a stable scapula when those muscles are active moving the arm. And again, that's what makes the shoulder complex so much fun, is looking at the complexity that occurs between the regions that influence motion at the joint. So let's get a little better feel for anatomy of the scapula, and we can start with the acromion. And the acromion is really just that attachment point for the deltoid, the upper trapezius, and the coracoacromial ligament. As I move across and look at the coracoid process, then that coracoid process is a little bony finger that projects anteriorly and attaches, provides an attachment point for the pec minor and the short head of the biceps brachii, and the coracoacromial ligament, and actually the coracobrachialis muscle as well. When I continue across, look at the glenoid cavity, or the glenoid fossa, that serves as that articulation with the humerus, and also serves as an attachment point for the glenoid labrum. And the glenoid labrum is that cartilaginous structure that deepens the joint cavity and provides increased stability. Functions very similarly to the meniscus in the knee. When I look at the inferior angle, attachment of the teres major and the latissimus dorsi, the infraspinous fossa, which is where the infraspinatus lies, and then along the lateral border, the teres major and the subscapularis attach. As I move to the medial border, we can appreciate the attachment for the serratus anterior. We can look at where the levator scapula attaches. The rhomboid, major and minor, both attach along the medial border. And then what separates the glenoid cavity and the coracoid process from the rest of the scapula is the neck of the scapula. A couple of other important components: the spine, which is a palpable structure, is the attachment point for the middle traps and lower traps, as well as the posterior deltoid. The little spinal glenoid notch is an anatomical area, which is the convergence of the acromion, the spine, and the neck. And then the subscapular fossa, which is a large area where the subscapularis attaches, with some attachments of the serratus anterior. The superior angle is the attachment for the levator scapula, and the border is the attachment for the omohyoid. The omohyoid we'll look at when we look at the visualization of these muscles. It's kind of fun because it's a muscle that actually has a tendinous attachment at the bone, becomes muscle tissue, becomes tendinous again, it becomes muscle tissue again before it attaches in the hyoid. The supraglenoid tubercle is the attachment for the long head of the biceps brachii, and the suprascapular notch is that point at which the suprascapular nerve passes. So we sometimes will see a impingement on the suprascapular nerve as it traverses across the notch. And the one point that is not labeled on my diagram is the infraglenoid tubercle, which is the attachment for the long head of the triceps tendon. So that's a good look at what the scapula looks like and its unique bony arrangement, and we can put the two of them together now and start looking at some ligaments. So we're going to transition into the muscular system of what drives shoulder function, and have an opportunity to look at the muscles that work so intricately together. And again, I talked a little bit, mentioned briefly earlier, that we can examine the shoulder with three different components. We can look at those muscles that attach from the trunk to the scapula. We can look at those muscles that attach from the scapula to the humerus, and we can look at those muscles that attach from the trunk to the humerus. And they all have a little different role, and they all have some very synergistic characteristics. So let's go ahead and start taking a look at those muscles that well, let's go ahead and look at those muscles that attach from the scapula to the humerus, since we've started at the hand and we're kind of working our way up. So let's start with the deltoid muscle, and we can look at the deltoid muscle and split it into three distinct regions. We have an anterior portion, and the anterior portion, or the anterior head, sometimes we'll call that the clavicular portion, originates on the lateral third of the clavicle and inserts in the common insertion point of the deltoid tuberosity on the humerus, which we identified earlier, innervated by the axillary nerve, and in space is responsible for flexion and internal rotation of the humerus. When I come over and take a look at the middle deltoid, sometimes referred to as the acromial portion, it starts on the acromion process and then courses down and inserts into the again into that common attachment at the deltoid tuberosity, innervated by the axillary nerve. And this is the muscle that we look at in terms of pure abduction of the humerus. And then posteriorly, we can look at the posterior delt with its attachment along the spine of the scapula, and again insert into the deltoid tuberosity, innervated by the same nerve, the axillary nerve, the C5-6 level, and it externally rotates the humerus and extends the humerus. So the deltoid is kind of an interesting muscle because we've got an antagonistic component between the anterior deltoid and the posterior deltoid, but when all three work together, we get we actually get abduction of the shoulder. But abduction of the shoulder, or flexion of the shoulder, really have to, that whole idea of getting your arm up over your head really has to occur with a synergistic muscle force couple that occurs with the rotator cuff. So let's take a look at the rotator cuff. So when I examine the rotator cuff, I can see from an anterior view the subscapularis with its broad attachment along the fossa of the scapula, and then inserting into the lesser tubercle of the humerus. So we can see that the function in isolation of the subscapularis would be medial rotation of the humerus, and a little bit of a prevention of anterior displacement of the humerus, which really occurs by controlling the amount of external rotation that's occurring. It's innervated by the upper and lower subscapular nerve at the level of C5 and C6. That's how that muscle works in isolation. But let's take a look at the other three rotator cuff muscles, and then we can examine how they work in a force couple to help position the humeral head against the glenoid fossa while working in conjunction with some of the major movers of the humerus, like the deltoid that we just looked at. So when I spin around here and look down on a superior view in the supraspinous fossa, I can see the supraspinatus muscle, and it originates, its proximal attachment is in the supraspinous fossa, that area between the superior angle here and the spine of the scapula, and then courses through that space that is created between the clavicle and the humeral, or excuse me, the clavicle and the acromion process. So that subacromial space is where the supraspinatus would course through and attach to the superior portion of the greater tubercle of the humerus. And in isolation, it assists the deltoid in abducting the arm and stabilizing the joint. But we'll also see that it is, again, a humeral head positioner, depending on the motion of the humerus and where it is in space. As I come posterior, in that area beneath the spine, we have the infraspinatus. And the infraspinatus really attaches along the entire infraspinous fossa and inserts in the posterior aspect of the greater tubercle, innervated by the suprascapular nerve, and laterally rotates the humerus. Again, that's in working in isolation. And its little helper here is the teres minor. And again, teres minor starting on the lateral border of the scapula, inserting into the posterior inferior aspect of the greater tuberosity of the humerus, and responsible for lateral or external rotation of the humerus. But we'll examine the rotator cuff in much more detail to recognize that it really functions as a force couple to minutely and finitely position the humeral head against the scapula as the scapular stabilizers position the scapula against the humeral head to provide maximum stability to that joint. So let's take a look at the anterior shoulder a little bit and some of those big movers that I talked about that attach from the trunk to the humerus. And the primary anterior muscle that does that is the pectoralis major. The pectoralis major is kind of fun because of its triangular shape, and it is classified as a triangular muscle. And we can look at the different attachments, the different insertion sites and origins, or the medial and lateral attachments. So when I do take a look at the origin, we can see that there is a clavicular origin that comes down and twists into its attachment. So we can see that we have the clavicular attachment, we have a sternal attachment, we have attachments into the true ribs, and we have attachments into the aponeurosis of the oblique muscle, the external oblique. And then again, it rotates up and twists and to attach into the rim of the bicipital groove. So it's along the medial rim of the bicipital groove. And what that does is it does provide the muscle with the opportunity to generate greater force and maintain a better length tension relationship. So when I look at what the function of this muscle is we can appreciate that it, by its attachments, that it'll immediately rotate the humerus. It will flex the humerus and will adduct the humerus. I think it's important to recognize when we have tightness in the pec minor, it may limit our ability to externally rotate the humerus, and that may provide a change to the glenohumeral joint mechanics that can in fact impact our ability to get our arm up over our head, or limit our ability to get inferior glide in the humeral head during elevation. The other muscle that we want to take a quick peek at is the coracobrachialis. Coracobrachialis attaching on the medial surface of the humerus and inserting in the coracoid process of the scapula. And it's responsible for, it's primarily a shoulder flexor, assists in shoulder flexion. So it'll help the anterior deltoid and the pec in elevation of the humeral head, or excuse me, elevation of the humerus. When I look to the posterior side, the biggest muscle on that posterior aspect that comes to my mind right off the bat is the latissimus dorsi. And the latissimus dorsi is a hugely broad muscle that has influences on so many different areas of the body, not just the shoulder joint. But let's take a quick peek at what we are looking at in terms of the latissimus dorsi. And again, it is responsible for a number of things, one of which includes medial rotation of the humerus, adduction of the humerus, extension of the humerus. It is an accessory breathing muscle, which we've talked about before. And we can see that its attachment is a little bit more anterior in kind of inside the bicipital groove. So it rests right inside the bicipital groove. Courses to its origin, which is along the spinous processes of T7 to T12 and L1 to L5, and includes attachments. When we take a look at it, into the sacrum, the thoracolumbar fascia, the inferior portion of the scapula, the posterior aspect of the iliac crest, and the 9th through the 12th ribs. So you can just imagine how much influence this muscle has over not just arm motion, but breathing, trunk mobility, trunk stability, hip function. So we have to really appreciate the relationship that is developed between the latissimus and the hips, latissimus and the shoulder, and now we can start to see an anatomical link between what is occurring at the hips through the trunk, attaching to the scapula, passing the glenohumeral joint, and inserting into the humerus. So we can truly see that there is a direct mechanical, anatomical, fascial link between your hips and your shoulders and your arms. So truly we can say the big toe is connected to the little finger. This little muscle is called the lat's little helper. I thought I'd throw this in after taking a look at the extensive opportunity that the lats provide the shoulder. We can take a look at the teres major, and the teres major again is affectionately called the lat's little helper, and originates on the inferior angle of the scapula, inserts in the kind of the lateral aspect of the rim of the, or the ridge of the bicipital groove, innervated by the lower subscapular nerve, and has the same actions as the lat. So we can see that extension, adduction, and internal rotation of the humerus. And if we turn our model around here a little bit, we can see that the attachment is a little bit anterior to the humerus, on the humerus, so it allows that internal rotation. And this view kind of shows us nicely that way that muscle wraps around the border of the scapula to provide internal rotation, as long as the scapula is in fact in a stable position. So let's take a look at those muscles that attach from the trunk, various portions of the trunk, into the scapula. And the first one we'll take a look at is the levator scapula. And the levator scapula has its origin on the transverse processes of C1 through C4 and inserts into the superior medial border of the scapula, the superior angle. Innervated by the dorsal scapular nerve, as well as some branches from the spinal nerves off of C3 and C4. And it functions to elevate the scapula and kind of immediately upwardly rotate that corner. So when we look at the levator scapula, we can also look at it in terms of what it does in a forced couple with pec minor and the rhomboids as a contributor to downward rotation of the scapula. So as I continue along and take a look now at the rhomboids, the rhomboid major is also a downward rotator of the scapula. Its origins are on the spinous processes of the second thoracic through the fifth thoracic vertebrae, and inserts along the medial border of the scapula below the spine. And it adducts the scapula also, again, with that in that forced couple, will provide some downward rotation. Now the little brother to the rhomboid major is the rhomboid minor, and the rhomboid minor is slightly superior to the major, originating on the spinous processes of C7 and T1 and inserting into the medial border of the scapula above the spine of the scapula. So that's a differentiation between the rhomboid major and the rhomboid minor, is the minor attaches above the spine of the scapula, innervated by the dorsal scapular nerve, and it works really to provide scapular stability, adduct, and downwardly rotate the scapula. So we've visited the trapezius before, but we want to take a closer look at its implication and opportunity that it provides the scapula for stability. And it's a big, huge, broad muscle, so we have to really separate it into various locations. And we can see that it has a wide origin and fairly complex, extensive insertion. So we can look at the upper trap as having an insertion along the head and on the occipital bone and the ligamentum nuchae. The spinous processes for the middle, T1 through T12, T1 through about T7 for the middle, and then T8 to T12 for the lower traps. And the insertion is just opposite of the deltoid. So we have insertions into the lateral third of the clavicle, which is just the opposite of the anterior delt, into the acromion, just opposite of the middle delt, and along the spine and the base of the scapula, just opposite of the posterior delt. So in isolation, it elevates or allows you to shrug your shoulders, but as a member of the forced couple, works in synergy with the serratus anterior, upper trap, and lower trap to upwardly rotate the scapula. So this is a muscle that I will often have to spend considerable time retraining in individuals that have poor scapular mechanics that result in impingement, anterior shoulder pain, because we're not getting enough upward rotation. And a lot of times it's a function of the lower trap not overcoming the upward pull of the upper trap. So we have lost that synergistic action between those two, that countering of the upper and the lower traps, and that's why I'm quite honestly, and when we're in looking at exercise programs, and I've got people coming in and they're doing a lot of shoulder shrugs in the gym, I get very, very concerned, because they typically are not doing anything to strengthen the lower trap. So we get this muscular imbalance between the upper trapezius and the lower trapezius that results in a lack of scapular rotation and more scapular gliding, upward gliding. So let's shift our focus to the front anterior aspect here and take a look at the pectoralis minor first, with an attachment along the 3rd, 4th, and 5th ribs and insert it into the coracoid process. The function of the pec minor is elevating the ribs and downwardly rotating the scapula. So it'll immediately rotate and downwardly pull the scapula. So it works with the rhomboid and the levator scapula in terms of having active downward rotation. One of the things to consider, though, with the pec minor is when it is tight and dysfunctional, is it won't allow the scapula to upwardly rotate, and as a result, we end up again with that change in scapular humeral mechanics and a dyskinesis that occurs with the scapula against the humerus. So we end up with impingement syndromes occurring with tightness across the pec minor. When I take a look now at the serratus anterior, the serratus anterior is this large scapular stabilizer that attaches to the upper 9 ribs, 8 to 9 ribs, including the first. So the function of the upper fibers of the serratus anterior will have a little bit different. The upper fibers have a little different function than the lower fibers, but primarily the function of the serratus anterior is to protract and upwardly rotate the scapula. So this is the muscle that works together with the upper trap, the lower trap, and then again the serratus to upwardly rotate the scapula, to position the glenoid fossa to maximize stability for the humerus, for the humeral head. So it attaches medially along the inferior rim, so we can see its attachment that comes all the way across on the fossa, the subscapular fossa, innervated by the long thoracic nerve. And this is the muscle that you'll see if it's weak or dysfunctional in people, where you'll have, from a posterior view, that medial border of the scapula will wing up, it'll tilt up, and that's a function of the inability of the serratus anterior to maintain appropriate scapular position. So that's kind of where we are in terms of muscular anatomy, and we're going to take next time and look at how these muscles function and the ligaments associated in the glenohumeral joint and the shoulder complex, so that we get a good understanding of the complexity and the relationships that have to occur for normal shoulder function to occur in space and occur in function in kind of everyday life.